Now, before I start for the day, let me just, it's kind of a fun thing, or interesting thing, I should say. And that is, it's been all over the drug news this week, and I've gotten a million emails about it from various publications. But this I'm reading is from the New York Times. The first digital pill ever devised has been approved by the FDA. And what it is a pill, it's a medication that has a sensor in it. So that when the patient, well, let me read this to you. And the ironic thing about it is, it's a medication for that paranoid schizophrenics take. Yeah. So they're tracking their pill ingestion. Anyways, let me show you this. The FDA has approved a digital pill. It's a medication embedded with a sensor that can tell doctors or whoever when the patients take their medications. It marks a significant advance in the growing field of digital devices designed to monitor medicine taking. And when patients don't adhere to lifestyle or medications they're prescribed, there can be substantive consequences and so on. And they've been kind of semi-doing this for tuberculosis medicines. Because a lot of times, you of course have to stay out and take them fairly religiously. And many patients who are on them are homeless or otherwise not tremendously competent. So they've been tracking them for a while. But it was never approved. Anyways, this is it. Patients who agree to take the meds, it's an antipsychotic drug called Abilify. They sign a consent form, and then the doctors or family members, whoever wants to, up to 4 people, can receive electronic data showing the date and time the pill was ingested. Smartphone app lets them change their mind and track it and so on and so forth. So, I'll jump along here. A system that will monitor their behavior and send signals out of their body and notify their doctor. You would think that in psychiatry or general medicine, drugs for almost any other condition would be a better place to start than a drug for schizophrenia. The sensor contains copper, magnesium, and silicon, safe ingredients found in food. And it generates an electrical signal when splashed by stomach fluid. They call it a potato battery. So it's like when you eat it, the gastric juice activates somehow the sensors, and it sends a signal to a patch. After several minutes, the signal is detected by a Band-Aid-like patch that must be worn on the left rib cage. It's replaced once a week. Then that in turn sends a signal to an app, a phone app, a computer, whatever you want to. The company hasn't talked about what they're going to charge yet. The chairman of psychiatry at Columbia University said many psychiatrists would likely want to try Abilify, especially for patients who experience their first psychotic episode and are at risk for stopping medication. I guess many patients who take this med, once they feel better, they stop taking it, which is probably not a good idea. So anyways, I just thought it was kind of interesting. Of course, there's a lot of ramifications, and now they're talking about, well, what if the courts get involved and they require that you take medicines, and if you don't, you get arrested, and I mean, there's a whole bunch of ramifications from this. But they also have another form. It's made of magnesium and silver chloride. It's encapsulated with the pills, and you don't have to use the patch. It gives out a low-power radio signal that can be picked up by an antenna that you wear around your neck. Anyways, this is this is the future. I just thought it was kind of interesting. This is the future. Now it's FDA approved, so you're going to see more of it. So, anyways, it's kind of interesting. Would you sign a form and let them track your pills? I'm not sure I would. Okay, let's go to work. Page 230. We left off with the continuing with the opiates, and as far as the schedule goes, it was pointed out to me, thank you, that we have class today and tomorrow. Then we're off next week for Thanksgiving. You get a much deserved break. I know how hard you work and you get to eat a lot of turkey and have fun. That's a good thing. Then the following week we come back and we have one class left, and then the final exam. And if you recall, I do the final exam and then exam number 3. Let me start again. That digital pill's got me all. We have class today and tomorrow. Next week's Thanksgiving, so we have a break. The following week we have our final class on Thursday for the semester. The next day, Friday, is test 3. Then the following week is the final. I put the tests back to back because then you only have to study one time for the same test because it's the same material on both tests. So it's actually, it seems odd, but it's actually to your benefit to do that. So what I will do tomorrow at the end of class is talk about what's going to be on test 3, even though it's not next week, it's the week after. Only because if I wait till the Thursday, it's going to be the day before the test. Okay? So that's kind of our schedule coming up for the next couple weeks.
Or is it just chapter 11?
Just opiates, yes. And non-opiate drugs we're going to do today and tomorrow. So yes, just chapter 11.
So the final won't have stuff from the first test?
Oh no, the final is made up of all 3 tests. And what I do for the final is I literally give you the exact same questions that were on tests 1, 2, and 3. And because my purpose, what I like to do is say, look, we're halfway there. Let's stop, look back over the semester, remember why you got what you got wrong, remember why you got what you got right, because it was a long time ago to September. And let's review and just kind of summarize, repeat again, everything once, and then we'll start up with the muscle relaxants as soon as the next semester starts. It seems odd, I know a lot of people ask me, oh, we'll do the muscle relaxants first, but it's the largest volume of material as far as classes of drugs. There's just so much stuff. It's not hard, there's just a lot of it. So it takes several weeks, and I'm going to start that as soon as we come back in January. So that's a little bit of the schedule upcoming. Okay. All right, page 230. We've been through the effects. I said I wanted to go through each of these. As far as analgesia, respiratory depression, sedation, euphoria, the cardiac effects, cough suppression, meiosis, and went through skeletal muscle rigidity, the tight chest, and the smooth muscle spasms, biliary spasm, and so on. The next thing I think we better talk about is nausea and vomiting. So let's go to the next page, 231, and we'll talk about that. And I'll go on the camera and point. Page 231. Now I apologize, you can't see too well because the yellow color, but there's actually lines pointing from all these things towards the middle. But anyways, let's get some background. Opiates cause nausea and vomiting. I mean, that's one of their main effects. We don't like it, but that's what they do. And it's very prominent action. Most patients at least feel nauseated, if not vomit. But it's fairly complex, the action, and so we're going to talk a little bit about it. Of all the drugs we give, The opiates are the number one culprit for causing PONV, or post-op nausea and vomiting. And many people now, especially in outpatient 30-minute, 45-minute procedures, try to avoid opiates altogether because, well, several things. That makes the patient less likely to have nausea and vomiting in PACU as well as when they go home. We have other analgesics now, IV acetaminophen, IV Advil, that are very effective, cost effective too, and they can be given without any risk of nausea and vomiting or respiratory depression. And so there's just different techniques that we can try for little quick procedures that don't require a lot of analgesia to provide the analgesia necessary, so we can avoid all this mess. But nonetheless, the opiates are notorious for causing nausea and vomiting. Now, here's what happens. It's fairly complex, so I'm going to talk about this for a few minutes. There's two areas in the brain that elicit nausea and vomiting. All right, one is called the CTZ. Somebody's probably talked to you about it already. This guy here wrote this little chart, so let's read what they said. The chemotactic trigger zone, CTZ, that's the box right in the middle I'm pointing to, is located in the area postrema of the brainstem. All right, the CTZ is unique in the brain, one of the unique areas in the brain, in that there's no blood-brain barrier there. And the real function of the CTZ, one of the other I think more important functions of the CTZ, is it senses how much oxygen is in your blood and helps you, if you get hypoxic, then you breathe faster. That's one of the signals comes through the CTZ. And that's why there's no blood-brain barrier there, because it has to have direct access to the blood so it can sense the amount of oxygen in there. Now, what drives respirations is CO2. However, oxygen also plays a role. So you can have low oxygen, and that's also going to make you breathe harder. And that's the part of the pathway that it does it, is through the CTZ. Well, because the CTZ has no blood-brain barrier, then the other action it does is causes nausea and vomiting. And the way people think about it is it's more of the immediate gagging and vomiting and so on. Let's say that you go see some gory horror movie and somebody chops somebody's head off. I don't know, it's not so shocking anymore. You see it on the internet every day. But, it's kind of gory and it makes you sick, or if somebody smells something particularly bad, and that the smell makes you gag and that kind of thing. I had hepatitis when I was younger. Back in the 70s, I caught it from a patient. Blood transfusion. I was giving blood. Massive transfusion in a trauma patient. And two of us, both CRNAs in the room, caught hepatitis. And we ended up in a hospital in rooms next to each other in isolation. And one of the oddest things about it was, whenever I smelled orange juice, I gagged and threw up. I have no idea why. And I couldn't drink orange juice for about 20 years. Now I drink it all the time. But it lasted for a long time. I have no idea why. But it was one of those things where I would smell it, they'd bring it in the room on my hospital tray, and I would have the thing, and I was like, whoa, and you're going to hurl. So it's kind of immediate fasting. Now there's a vomiting center also in the brain, separate from the CTZ. So let's read what the guy says here. CTZ, located in the area of postrema, contains all these things, and we'll talk about that. The vomiting center receives input from the CTZ, see the little arrow, as well as peripheral sites via the vagus nerve. So your gut has a lot of sensors for nausea and vomiting. So in case you eat something that's particularly nasty, it makes you throw up to get it out of there, and that's a normal body function. It's not a happy body function, but it's normal. You've all been there. But the vomiting center is more of a chronic, low grade. It's the mom whose first trimester gets a nausea and vomiting or morning sickness when they're pregnant. And it's like hours and hours. They just feel nauseated and maybe they won't especially vomit, but it's just they feel sick and stuff. And that's more of a vomiting center thing, where the CTZ is more of an immediate, quick reflex type of nausea and vomiting. But nonetheless, there are both areas in the brain that can elicit both nausea and vomiting. Now here's the ticket. If you look, well, let's start clockwise, so around the top here. The CTZ has serotonin receptors, histamine receptors, acetylcholine receptors, opiate receptors, benzodiazepine receptors, and dopamine receptors. So there's just about every kind of neurotransmitter can influence both the CTZ and the vomiting center and play a role in you getting sick. Now here's the funny thing. The opiates stimulate the CTZ, so they can stimulate you throwing up. So you get a shot of morphine, and especially it's postural, but you get a shot of morphine and then all of a sudden the patient's nauseated and they're throwing up and they're asking for an emesis basin, and you all been there. But it also at the same time inhibits, here's it says here, the vomiting center. So it has complex effects. It stimulates the CTZ, and that makes you throw up quick, but it inhibits the vomiting center, which is a slower, more long-term thing. So here's what happens. This is what happens clinically in the real world. And I'll say it about 10 times until you don't want to hear it anymore. Anybody who gets a narcotic is a higher risk for nausea and vomiting. Period. That's statement number one. That's a truism of pharmacology that'll never change. Anybody who gets a narcotic is at a higher risk for nausea and vomiting than a non-drugged patient. All right. However, the risk is highest with initial dosing. In other words, if somebody's getting morphine on the floor for 3 or 4 days, the first dose is more likely to throw up than the second dose. Second dose more likely than the third dose. And eventually, the inhibitory effect on the vomiting center will temper the stimulatory effect on the CTZ, and after 24 or 36 hours, they're not throwing up anymore. So if somebody gets morphine for pain and they throw up, well, you can give them another dose. Chances are they're less than they'll throw up the second time, and less they'll throw up the third time. So as time passes, the inhibitory effect on the vomiting center catches up with and tempers the excitatory effect in the CTZ, so then the incidence of nausea and vomiting go down as the longer the treatment is. All right, see what I'm trying to say? Let me say it again. Anybody, any dose, for how long, no matter how long you've been on it, let's say you got oncology patients who are on high doses of opiates for weeks, months, patches, all kinds of vehicles for administering narcotics, and they're always at higher risk for nausea and vomiting than a patient who's not being medicated. However, the more doses you take, the longer the duration of treatment, the less likely it is that you're going to throw up because of the inhibitory effect on the vomiting center. So all opiates stimulate the CTZ, that causes nausea and vomiting, but they also inhibit the vomiting center, which will eventually help minimize, not totally, but to a large extent, the effect on the CTZ. Does that make sense? All right, so let's take a look. Yeah? Thanks. Oh, you can't take notes. All right, we'll start here. The CTZ has serotonin receptors. And if you block serotonin receptors, that's anti-emetic. And specifically, the number 3 receptor. So 5-HT is 5-hydroxytryptamine. That's the other name for serotonin. Right? It's the same thing. One's a generic name, one's a trade name kind of thing. Not really, but similar. So 5-HT is serotonin. And the serotonin 3 receptor specifically is one that causes nausea and vomiting. So if you give a 5-HT3 inhibitor, and the classic thing is, of course, Zofran, ondansetron, then we're going to talk about the drugs here in a minute, then that's antiemetic, all right? Histamine. Stimulating histamine receptors in the CTZ causes nausea and vomiting. Therefore, antihistamines tend to have an antiemetic effect. So, Benadryl and other antihistamines have a mild antiemetic effect. The problem is they make you so sleepy that, well, I guess it's not a problem if you're going to bed, but if you're trying to function, then you're real sleepy even though you get an antiemetic effect. All right, acetylcholine causes nausea and vomiting. And so anticholinergic, or more specifically antimuscarinic, drugs are antiemetic. And the classic example of that is scopolamine. And if you ever went on a cruise, all the old people are running around with scopolamine patches behind their ear, and they got a dry mouth, and their eyes are dilated about this big. They can't see anything, but they're not seasick. So scopolamine, there is marketed as a patch for us. There is product that we can use in the OR. The problem is very slow onset. You can imagine you put a patch on, it's not going to be immediate rescue drug. And you have to give it to the patient to take home and put on the night before surgery. And then by the time they come, they'd have some antiemetic effect. And scopolamine is mostly for motion sickness, car sickness, plane sickness, cruise ship sickness, etc., where it's vestibular in the ear, motion and stuff. Then scopolamine is good for that. It's drug-induced nausea and vomiting, which is what we do, or we make, is not that effective. But there is some on the market. I don't see anyone using it. All right. Of course, dopamine is a very prominent emetic neurotransmitter in the brain, and the anti-dopamine drugs are the most powerful antiemetics. That's droperidol, haloperidol, we talked about already, metoclopramide or Reglan. Those are all excellent antiemetics by blocking dopamine. Phenothiazines, thorazine, compazine, stelazine, onward. So anything with an anti-dopamine effect is a good antiemetic. The benzodiazepines and propofol have a mild antiemetic effect. I talked before about Ativan being used in oncology patients. And propofol, if you give an infusion, so they put inhibit, question mark, so it kind of inhibits, but you got to give bolus followed by infusion. So these are all the methods that you could use to cause an antiemetic effect. Now, of course, here's the opiates, and they stimulate the CTZ, they inhibit vomiting center. So that's what we talked about there. Then finally, what they're showing here is peripherally in the stomach, in the pharynx, the back of your throat. You can get gag and make you throw up and stuff. So in some areas in the stomach and the GI system, via the vagus nerve, can send signals up into the CTZ and so on to make you throw up. So that's a little bit of the picture, and as I said, it ends up being pretty complex. So anyways, let me finish by saying one more time. There are multiple neurotransmitters in the brain that can cause nausea and vomiting, including dopamine, serotonin, histamine, acetylcholine, and there's some other prostaglandins. Therefore, antiemetic drugs can work on any of these transmitters, and there's many different classes, You can have an antidopamine drug, a serotonin blocker, a histamine blocker, or a acetylcholine blocker, all having an antiemetic effect. As far as the opiates go, they all produce nausea and vomiting. Their incidence is the highest with initial dosing, but it decreases when you give subsequent doses because of inhibition of the vomiting center, which eventually catches up and helps temper some of the stimulation of the CTZ. People are less likely to throw up if they don't move around. There's a postural component or a vestibular component. So our patients, because they lay still and don't go anywhere, we hope, we do our best to keep that way, lay on the operating room table and don't move, then our patients are not as prone to throwing up. Where we see nausea and vomiting, of course, is in the recovery room, because the patient's trying to get up and get dressed and go home. So they're starting to move around, and that's when they see the issue. We rarely, if ever, see it in the pre-op or in the intra-op. Pre-op because we don't give more than just a touch every once in a while, or nothing. And the intra-op because the patients lay still and don't move, so we don't really see it in the OR. We see it post-op. And so, and pharmacologically then, the opiates stimulate the CTZ and inhibit the vomiting center. So does that make sense? Let's look at, I took out of my chapter 14. Chapter 14 in my book, I wrote it, it's called Additional Drugs of Interest. I had some drugs I wanted to talk about, but I didn't know what other chapter to put them in. So it's kind of like potpourri, chapter 14. I had to come up with a name, so my editor suggested Additional Drugs of Interest. I said, oh, that sounds nice, let's do that. So we have antibiotics in there to talk about surgical infections. I put psychiatric drugs in there to talk about their anesthetic implications. And then I have a section on anti-emetics. So it's page 195 to 197, if you want to write that at the top there. It's only 2 pages. Page 195 to 197, chapter 14 in my new 6th edition. And that's where this comes from. So let's take a look at what I wrote. I just got a little bit of it here. The anesthesia on the bottom of page 231. The anesthesia communities put tremendous effort into addressing the issue of PONV and post-discharge nausea and vomiting. The undesirable responses to anesthesia are unfortunately persist. It's one of the most common issues that patients deal with. The complication may result in incisional stress, and if somebody has a jaw wired shut, if they had a maxilla done or some facial procedure with wired, and they throw up, of course that can be a disaster for aspiration. Neurosurgical procedures, upper GI surgery, and so on. Bleeding, fluid, electrolyte disturbances, cardiac and aspiration may occur. In the PACU, discharge may be delayed, and hospital readmission can occasionally happen. It uses more resources and personnel with increase in cost. In a widely reported recent study, the risk for post-discharge, that's after 24 hours when the patient goes home, it was noted that the incidence of nausea and vomiting was higher after discharge than in PACU. So it's kind of out of sight, out of mind, and we don't think much about it. But actually, the patient is going home and worse than they were in the PACU. We don't want that to happen either. In the PACU, 19% of the patients has nausea, with, I'm rounding, 4% had vomiting, and severe nausea was about 3.6%. Severe vomiting, 0.2. At home, after discharge, 36% had nausea and 11.9 vomiting. So this actually went up. That's not good. Multiple risk factors have been discussed, although a few have been identified as significant. I have it on the next page. Significant risk factors for PONV or PDNV, post-discharge, differ slightly, and they're on the next page. Now, our current approach to almost anything in medicine nowadays is the ever popular word multimodal, because the effect or emetic effect of drugs comes from the numerous receptors that we just talked about on the previous page, from dopamine, serotonin, histamine, acetylcholine, etc. Then giving drugs that can affect small amounts of drugs or multiple drugs that can affect the different neurotransmitters can be usually more effective than giving higher doses that just affect one neurotransmitter, because maybe that neurotransmitter is not the one that's causing this patient's problem. So maybe you're attacking dopamine, you're giving an anti-dopamine drug, but their nausea is coming from serotonin or acetylcholine or whatever. So giving smaller doses of multiple drugs seems to be more effective, and so on. So, what else did I say? Preference or use of propofol infusions, avoiding volatile anesthetics or nitrous. It's not easy to do, but in small procedures. Reducing the use of opioids, and adequate hydration all seem to be helpful. So the next page, I made this little table up. These are the absolute significant risk factors for nausea and vomiting. Women greater than men, age less than 50 years old. If you have a history of PONV, that's the number one risk factor. If a patient comes in a pre-op and tells you the last time I had anesthesia, I threw up, first thing almost every CRNA anesthesiologist will do is go, well, that wasn't me. That was them. I do much better anesthesia. They're not going to throw up. Yes, they are. It isn't them. It's the patient. And if you have a history of it, you have a history of it. And that's a strong indicator. If they got high doses of opiates, of course, that's going to make a big difference. The longer the surgery, the more prone. And laparoscopic seizures are certainly more prone for the obvious reason of that big belly full of gas. Post-discharge nausea and vomiting, the risk factors are, again, female, gender, age less than 50, history of PONV, and did you have PONV in the PACU? And chances are you're going to have it when you get, a good chance you're going to have it when you go home. So, multimodal anti-emetic therapy, bottom of page 233 there. Since nausea and vomiting are multifactorial, the multimodal approach using different drugs with different mechanisms is the most effective. And so several classes of drugs are used. Number one, let's start with steroids. This is immensely popular today. And you have to spend more than 5 minutes in any operating room hanging around anesthesia people to see that we give dexamethasone, like water, as an antiemetic drug, as a prophylaxis to prevent it from happening. So turning to page 234, dexamethasone is a very popular drug for the prevention of nausea and vomiting. A dose of 4 milligrams IV is recommended after anesthesia induction rather than at the end of surgery. So give it early. I'm talking about a 14-hour case, but an average case of 1 to 2 hours, and you want to give it early in the case so that it has a couple hours of work before you wake the patient up. You can give up to 8 milligrams. Some people give a little higher dose. The studies show that its efficacy is similar to Zofran, 4 milligrams, or droperidol, 1.25. So it's a pretty good drug. Some people, as I said, give a little higher dose of 8 milligrams, and that's fine too. Really doesn't matter. Now, I get to ask this a lot by emails and whatever. How does dexamethasone, how does steroids have an antiemetic effect? So this little statement here is going to tell you that I don't have any idea. But anyway, let's read it. Data from animal studies suggest it exerts its antiemetic effects through a central inhibition of the nucleus tractus solitari. Reduction in serotonin in the brain, reduction of via reducing the precursor for serotonin, which is tryptophan, decreasing release of GI serotonin, decrease in the 5-HT3 turnover in the brain, and inhibition of prostaglandins have all been proposed. So I think it's safe to say, how does the steroids have an antiemetic effect? I'd say by reducing serotonin. That's a pretty safe generic statement, both in the brain and in the periphery. It seems likely that's their effect. They have animal studies anyways, and possibly some prostaglandin effect. Now, I also mentioned, although steroids are associated with numerous side effects, with repeat use, and of course, you learn this in Nursing School 101, and every pharmacology book's got a table in there 5 pages long of all the chronic effects of steroids, and moon face, and buffalo humps, and changes all kinds of internal hormones, and I mean, it's a mess. Chronic steroid treatment is very serious. It has a tremendous effect on the body. But single injection, like we do, is very safe. No effects at all. The two things that we would worry about is it's known that it affects wound healing. So if somebody's on chronic steroids, they don't heal their incision as well. That's number one. So although steroids, I'm reading here again, are associated with numerous side effects with repeat use, a single dose for antiemetic effect is safe. The effect on wound healing and infection, they can mask infections. That's not a good thing either for us. Has recently been reported, and a single dose does not appear to increase wound complications. So the usual worry about masking infections and retarding wound healing is not an issue with single dose use. Now, a significant increase in blood glucose may occur. It does occur. I said may, but it does. 6 to 12 hours post-op in patients with impaired glucose tolerance, for example, that can be an issue. So I would say the only one not to do this in is don't do it in diabetics, because you're going to cause post-op hyperglycemia. Especially with a higher 8 milligram dose. Okay? Question?
Okay, question. So if a patient is already on steroids and we give them one dose for antiemetic properties, would that work or not?
Yes, it'll work. And it'll be actually safer because they're already tolerant to it.
Okay.
So. Okay, 5-HT3, I'm on page 234 again. The 5-HT3 drugs, which are probably the most prominent antiemetics on the market right now. Zofran is the most widely used antiemetic in the world. It's the gold standard for comparison for all other agents. And it's thought to have a greater anti-vomiting effect than anti-nausea effect. And that's good. The patients, you don't want them to have either, but if you have to have one or the other, you'd rather have nausea without vomiting, right? Standard dose is 4 milligrams. You give it at the end of the procedure. Its popularity arises in part due to the relative lack of significant side effects. Now that having been said, and I'm going to ask you this in the next test, Zofran causes an increase in QT interval, just like droperidol. So the two antiemetics that we use clinically that can prolong QT interval and may cause a cardiac arrhythmia, and you have to be careful using torsades and all the rest of that nonsense, are droperidol and Zofran. However, the difference is droperidol has a black box warning from the FDA on the label, and Zofran doesn't. So you don't have to do the EKG prior to administration. You don't have to worry about the lawyer standing outside the front door waiting to take your name and phone number. But pharmacologically, there's no difference. They both cause it. So if somebody has severe cardiac arrhythmias or cardiac disease, I would not be wouldn't be the first drug I'd pick. Is giving Zofran.
Does Reglan prolong your QT interval as well?
Reglan, metoclopramide. Not that I know of, but I have to look it up. Okay, standard dose is 4 milligrams at the end of the procedure. At higher doses, QT interval changes can occur. And they know this because of chemotherapy-induced nausea and vomiting. That's CINV, and that's here. So they were using doses of 32 milligrams for CINV. Now we only give 4. And in the CINV patients, they're getting some cardiac arrhythmias, etc. And just to go off on a tangent here, I'm already on one tangent, I'm going farther around. Most antiemetic drugs are tested in oncology patients because you want to test an antiemetic, then you want to find someone who throws up a lot from drug-induced issues and who has more than an oncology patient. So many of these drugs, almost all of them, are tested first in oncology, and so they're given in very high doses because they use a lot higher doses in those situations. And then eventually, after a couple of years, if it's effective, they may then bring it into post-op nausea and vomiting. So a lot of times we find out about some of these side effects, but they're at much higher doses. By the time they get to PONV, and we're using tinier amounts, and we don't really see a lot of the issues that go. Short duration, 4 to 6 hours, makes it unlikely to be effective for post-discharge nausea and vomiting. That's Zofran. Now, there's 2 other 5-HT3 blockers, and I'm on the last line here. One is called a granisetron, and the other one is dolasetron. That are also used, and there's a new one that started out with CINV and now it's made it to us, and that's called polonosetron or Aloxi, and it's out and available for everyone. And the thing about it is the half-life is 44 hours. The duration of action can be up to 4 to 5 days, single dose. So this is the one they're touting for PDNV because it lasts a long time. All right, why give Zofran for post-discharge nausea and vomiting when it wears off in 4 hours? This one doesn't. All first-generation 5-HT3 antagonists may adversely affect the QT interval, and they can also talk about serotonin syndrome. I'll do that later on. Okay, the neurokinin receptor antagonists, there's one, couple of coming our way. Aprepitant, Emend is an IV, and it's IV formulation. Fos aprepitant is a neurokinin 1 receptor antagonist. Now the prodrug, this they're talking about, is when you take Emend as a pill, it goes to the liver first, of course, as all pills do. We talked about that. And first pass, extraction, etc. So it's metabolized into its active metabolite, and then it works. When you give a drug IV, it doesn't go to the liver first. So it's not active. So they have to give the IV formulation, as it has to be different, so that it's more active when you give it IV. So that's why the pill and the IV form are different formulations. Okay? And the neurokinin receptor antagonists provide antiemetic activity by suppressing activity in the brainstem and the MST, where vagal afferents from the GI tract input with other inputs and produce emesis. So it's around, it's really expensive. I don't see it used a lot in anesthesia circles. It is used a lot in oncology, but there's a little write-up about it and so on. There's a couple of Me Too drugs coming out that have long half-lives, and we'll see if they make it to the OR. Let's quit there and take a break. Okay, let's go back to page 235, 235. Page 235. Okay, we got a couple left. I left off with, of course, droperidol, butyrphenones. We've talked about droperidol, but let me just reiterate. Small doses are used and it works by blocking dopamine receptors. It can produce Parkinson-like or extrapyramidal, same thing. Side effects is contraindicated in Parkinson's disease. Because of the black box warning and the prolongation of QT, it's fading in its usefulness. Transdermal scope, next page, 236. Scopolamine patch. You have to put it on the evening before surgery. Its onset is slow, 2 to 4 hours. I think it even takes longer. And duration of at least 24 hours. It blocks cholinergic impulses from the vestibular tract, which is mostly a motion thing. And finally, the benzodiazepines are not noted for having the antiemetic effect, but they can make you less anxious, which can make you have a mild effect. Metoclopramide on the next page, 237. It's a weak antiemetic because of its dopamine blocking abilities, but it also has the same cautions that droperidol does. Anything that blocks dopamine receptors is going to cause possibly Parkinson's-like symptoms and therefore be contraindicated in Parkinson's disease. So then finally, clinicians have established guidelines for the use of antiemetics based on common risk factors. Multimodal PONV and PDNV prophylaxis should be considered for patients that are at risk. All prophylaxis in children at moderate or high risk for PONV should include a combo of either a serotonin blocker and a second drug. So we usually give Zofran and dexamethasone or something like that. Because of the effects of interventions, different drug classes are additive. Combining them has an increase in risk reduction. When rescue therapy is required, when you go to PACU and somebody's throwing up in spite of your best efforts, the antiemetics chosen should be one from a different class than what they've already received, either earlier or prophylactically during the case. If PONV occurs within 6 hours post-op, patients should not receive a repeat dose of the same antiemetic. An emetic episode happening more than 6 hours post-op can be treated with any of the drugs mentioned above. That's kind of a general approach. There's a lot of variations. You'll see people learn about them in the OR, but that's basically it. The next page I just put in here. This is the current antiemetic meds that we have by class, and we touched on most of them, the ones that matter anyways. Then finally, the page 239, there's the doses and their route of administration. So, I've got them for you. Okay? Now that's enough about nausea and vomiting. Now, the next thing I want to talk about is, well, actually, I want you to mention a little bit about where the heck did I put it? I got it in here somewhere. show you this. I wanted to go to page 247. 247. And this is just some of the doses. I feel compelled to talk about this. I know you've learned it from other people. In fact, you're already doing it in the OR. But I just thought I would at least throw my 2 cents in there in case you asked. And I think morphine and Demerol, I don't have to tell you how to give those. But fentanyl is marketed in a 50 mics per ml solution. And look at the company recommended dose. 2 to 150 mics per kilo. Well, that's helpful. In other words, give as much as you want or as little as you want. It's up to you. That's a pretty wide range for effective dose, isn't it? In the older days, we used to use what we called high-dose fentanyl techniques, high-dose opiate techniques for open heart surgery. It's because you're trying to get the patient to not have any response at all to the sternum sawing and the other very invasive effects. But the problem is they sleep for 24, 48 hours afterwards. When you give them 100 and 150 mLs of fentanyl, they tend to stay down for a while. Now with fast tracking going on and trying to get patients extubated the same day, etc., we've gone to using anesthetic gases in much lower doses. Sufenta is also marketed as 50 mics per ml, but because it's 5 times more potent, then you can look at 1 ml of Sufenta as equivalent to about 5 mLs of fentanyl. Now, fentanyl came out first, and that's the standard we use for everything. And then every time the patent went off for one of their products, this was Janssen Pharmaceuticals, then they bring out another analog. So when fentanyl went generic, they brought out Sufentanil, and that was just 5 times more potent than fentanyl. And what people were doing is watering it down with 4 mLs of water. It's like, well, why would you do that? You just have fentanyl again, but now it costs you about 10 times as much. Anyways, Sufenta is the most potent opiate we have on the market. Any administration at all is going to make the patient apneic, and we reserve it for very large operations, very invasive operations, where you don't plan on extubating the patient at the end, almost always. Open heart surgery or radical neck, big spine surgeries, a Whipple procedure, something in a big abdominal case, a long plastics procedure, 12, 14, 16 hours. You can turn on a Sufenta infusion with your infusion pump, and that gives you a nice steady analgesia for the case. And if you don't worry about getting rid of it at the end, you're going to keep the patient extubated, send them up to ICU, for example, and they actually like that better. The patient stays calm. Alfenta was marketed next, and that supposedly is a little bit shorter acting than fentanyl. If you look in the books, say an average dose of fentanyl, I'm going to talk about this here next, will last about 30 to 60 minutes. Alfenta, they go 20 to 40 minutes. Really? I mean, is there that big of a difference? I don't think so. But it does have a little bit shorter kinetics, so it is a little shorter acting. So what some people use Alfenta for was in outpatient procedures where they want it to wear off fast, a little 30-minute case, 45-minute lumps and bumps surgery where it's for a healthy patient. Give them a couple mLs of Alfenta and leave it at that. Now, it's marketed as 500 mics per ml. So the difference between the 3 fentanyl analogs, fentanyl and Sufenta are 50 mics per ml, and Alfenta is 500 mics per ml. Why? Well, it's 10 times less potent than fentanyl, so they put 10 times more of it in the vial solution for you. So its potency is similar to fentanyl, even though it's inherently 10 times less potent. They did make it stronger to make up for that. See what I'm saying? So 500 mics of Alfenta is similar to 50 mics of fentanyl, and Sufenta is 5 times more potent than both. Now, remifentanil has a potency the same as fentanyl, but that's the one you have to use by infusion because it's going to wear off right away. And again, in the bottom there, they mentioned the loading dose is about a mic per kilo. Then infusions anywhere from 0.5 to 20, depending on the case and how the patient responds. And the nice thing about it is you can turn the infusion faster or slower and tailor it to the patient's condition. So I just thought I'd mention that. Again, I know you've had it elsewhere, but there you go. Now on the next page is the antagonists. We can make short strip of this. Narcan, I think everybody is familiar with. Naloxone. And naloxone or Narcan is marketed as 0.4 milligrams per ml. Little 1 ml vials. You've all given it. 0.4 milligrams per ml and 1 milligram vials. If you give Narcan to somebody, here's what you do. Anesthesia people do. You take a 5 cc syringe, you draw up an ml of Narcan. It has 0.4 milligrams in it, right? And you draw up 3 cc's of water in the same syringe. So you water it down. Now you got 4 mLs of Narcan. Each ml contains 0.1 milligram. All right, I'll say it again. You take a 5 cc syringe, you draw up 3 cc's of sterile water, or take 3 cc's out of the IV tubing, wherever you get it, who cares? You take 1 ml of Narcan, you draw it into the same syringe. So now the usual 0.4 milligrams per ml of Narcan has been watered down to 0.1 milligram per ml. Then you give it in 1 ml increments. So if you do have to reverse somebody, they're not breathing at the end of the case, you want to touch them with a little Narcan and see if that's the reason they're not breathing. You got rid of the relaxant. I talked about this last week. You got rid of the gas. You blew it all off. They're still not breathing. Their eyes look pinpoint. You know you've been giving them a lot of fentanyl. You think they're narcotized. You don't want to reverse all their analgesia. Touch them with a 0.1, just a little bit. Give it 1 or 2 minutes. See if they start breathing. If they didn't work, give them another ml, 0.1, etc. And titrate it is what I'm trying to say. Don't slam it in there. Give it in small. There's a little art to the administration rather than just injecting it in there. And try to get it to the point where the patient's just breathing. Now, you got to remember, if it took you Narcan to get the patient breathing, the Narcan's going to last 30 to 60 minutes. If there's a lot of narcotic around, they may have more narcotic than Narcan. And when the Narcan wears off, they'll stop breathing again. Re-narcotize, we call it, in recovery. So, hopefully in the 1 hour time that the Narcan's in there, the blood level of the opiate you gave will fall enough that the patient will keep on breathing. But you certainly want to inform the PACU nurse that you transfer the patient to, that you're concerned. Keep a special eye on them. Don't discharge the patient too fast, and see how they're doing, and so on. And it could be a safety thing. Does that make sense? Now here, naltrexone is a pill, so the most you're going to do is see. Nalmefene, we don't stock it in the OR, so it's just a long 8-hour lasting Narcan. They use it in ERs to reverse addicts. But naltrexone's a pill, and you see it around a lot because they're using it for alcohol withdrawal now. It seems to have some benefit in people that are in Alcoholics Anonymous or abstinent programs, and they're trying to stop being alcoholic, and so they give them this, and it seems to help with their desire to drink. So you may see a patient come to surgery, is my point, that is taking Vivitrol, the most common one that's used, naltrexone. And you just have to give more narcotics, right? Because it's competitive antagonist, meaning that, yes, you can give anesthesia to somebody that's on naltrexone. It's just going to take a higher dose. You got to compete with the antagonists. It's just a dose response curve to the right. You've, of course, been through that a lot. So we're back to Narcan. This little table up on top, I took from somewhere. I can't remember where it came from. But these are all the studies that have been done over the years showing that, Narcan is relatively safe. Here's what we think. If I took any one of you right now, assuming you're not narcotized, maybe from my voice, but not drugs. If I took any one of you right now and gave you 0.4 milligrams of Narcan, nothing would happen. You got nothing on the reverse. You're not releasing enkephalins and endorphins because you're not in pain, so you pretty much have no effect. It's a fairly innocuous drug. So, and it's true for 99% of the patients you give it to. They very rarely have side effects. The only thing you don't want to give Narcan to is to somebody who's an addict, because you're going to put them into withdrawal immediately, and that's not pretty. But nonetheless. But there has been a couple of cases, and they're looking here. There's the doses, the reports, and so on. 0.4 milligrams, 0.1 even milligrams C. And there's been some episodes of hypertension and pulmonary edema and so on. So there's been a couple side effects. All drugs cause side effects. Placebo cause side effects. But I mean, when you think about how many millions of times it's been used, and you can only find a table this big, it's a relatively safe drug. Now, of course, there's a tremendous interest in Narcan now in the news and the general public because of the opiate crisis that's going on right now. And so I put a little blurb in here. Interestingly, a recent medical letter article reported renewed interest in intranasal opiate Narcan because of an increase of deaths from opiate overdose. I'm reading on page 248. The FDA has approved a more practical alternative for emergency treatment, single-dose auto-injector. So you just push a button and it automatically injects it in there for somebody because obviously they're not breathing. It's kind of hard to give a nasal dose if they're not breathing and so on. It works a little bit better. It's available in kits containing 2 pre-filled 0.4 auto-injectors with a voice guidance and a trainer device that has voice guidance. So it tells, push it against the skin, push the button, that's what the person would say, little computer voice. Push the button and then all of a sudden the needle will inject 0.4. Manufacturer's not published a price, so yes they have. If you want to know, the price is I think around $400 a dose. So Narcan costs about $4 or $5 in the hospital when you draw it up in a syringe and give it, and they're charging about $500 a dose for this. But a lot of people are giving it away free. A couple of pharmacy chains have said that they would give it to families and EMT, ambulance type folks, and firemen, police departments, and so on are all starting to carry it now. So if they come upon a overdosed patient, they can at least blast a little Narcan in there. So then that's a good thing. Okay, I want to just mention on the next page, I put it in here, page 249, as far as opiate-induced constipation. I'll mention this, it's not an anesthesia thing, but just for completeness, just so you've heard this, I'm not going to ask you questions about it or anything. But obviously one of the main effects of opiates is they decrease GI motility and propulsion and all the rest. And I put a table on page 249, the effects of opiates on the GI tract, and you can see decrease, inhibit, etc. So they dry the stool out, make it hard, therefore they get constipation, decrease GI motility and gastric emptying, and onward and onward. So they cause constipation. And as I said, you never develop tolerance to it. And this is a major problem for people who take them, oncology patients and somebody who's on it for 3, 4, 5 days for post-op pain and so on. Again, it's not an interoperative issue, but it's certainly an issue with the drug. There's been several medications brought to market to treat what they call OIC. I even see commercials on TV showing this during the ball games. I don't know who's taking narcotics and watching a ball game, but they must do something. And what they did is this. It was kind of inventive. They take Narcan and they make it so it's not lipid soluble. It's totally water soluble. So they mess with the molecule a little bit, add a couple of something, methyl group or ethyl group or something, and just make Narcan so you can't absorb it. You take a pill and it just stays in the GI system. But it blocks the opiate receptors in your bowels and GI system without being absorbed and blocking them in your body. So you can still take a narcotic and it works in the body, but it's not affecting locally in the gut because the receptors are blocked. So it's kind of an inventive way to go about it. There's a couple of them on the market, Movantic, Relistor, and some others that are just basically analogs of Narcan, which they've altered to make them totally water soluble, like I said. So they work locally in the GI system, and they block the opiate receptors, and therefore you don't get constipation. But they still allow the narcotic to be absorbed if you're taking Vicodin or OxyContin or something, and it'll still have its effect peripherally. The Narcan just stays in the gut. So that's an example of drug solubility, and the drug is not soluble, and that's a good thing. Okay, enough of that. Let's go to the next page. I want to talk about dosing and so on. So I'm going to page 250, and I'm going to go on the camera and point. Page 250. Now these are, we'll go through a couple of these. These are computer simulations done with drug administration, IV, etc. And so I want to get this into your brain. And so what they're doing is this. They're looking at the fentanyl blood level, so it's the fentanyl concentration, over time. See, they go for 40 minutes. And with different doses. This solid line is 60 kilos, different size patients, I'm sorry. 60 kilo, 80 kilo, and 100 kilo patient, and 3 different doses, 100 mics, 150 mics, 250 mics. So 100 mics of fentanyl is 2 mLs, 150 is 3, and 250 is 5. And different size patients. And what they're saying is this. They put this line across here. This is the blood level. Above this, the patient is going to be apneic. It's going to be enough in the body to cause apnea. As long as the blood level is below this level, see respiratory depression line, then the patient's not going to be apneic. But they're going to be analgesic, because analgesia and respiratory depression and addiction liability are always the same. Or they go hand in hand, remember that? So, if I take let's pretend a 60 kilo patient, and I give 100 mics, then this is the line I got. So they're showing I got, that's 2 mLs of fentanyl in a 60 kilo patient, so an average sized person. And I got analgesia. I never got respiratory depression, and I got about 40 minutes. And that's what you're going to see in the OR. So you get a 60 kilo man or lady coming in for a knee operation, and you put them to sleep with propofol, or her to sleep with propofol, Sevo, and then you say, I'll give 100 mics of fentanyl in the beginning to cause some analgesia, And this is what your blood level's looking like inside the body. And, that's a good thing. It's not causing respiratory depression. Anytime they got a blood level of anything, they got some analgesia. All right. Now, what if you had to give more? Their heart rate was up, or they still seemed like they were light. So you went up to 5 mLs or 250 mics. Well, then you push the blood level up this high. See, so that patient is going to be apneic for the first 15 minutes after you gave that 5 mics. Then the blood level falls below the respiratory depression blood level. And they still have analgesia, but they're breathing, and that's a good thing. See, and then it's going to go out. You hear, probably get about 70 minutes out of it, 80 minutes. There you go. So again, I'm trying to get you to make a mental picture of what happens when the drug, when you put it in that tubing and give it, what's going on inside the patient. Well, 100 mics, you're getting this. At 150 mics, you tickle the respiratory depression line. But you didn't quite go there. But at 5 mLs, yes, you're going to make the patient not breathe. Okay? Now, you got a 2-hour case. You don't care if they breathe or not. You probably paralyze them with a bronchial anyways. But you can still have a mental picture of what you're doing to the patient inside. Where's the drug going? Now, let's say the case ends at 40 minutes. Okay? And, let's go to the next page. This is a similar thing, computer analysis. And what they're showing here is, this is 6.4 mics per kilo. So let's just make it 6 in a 70 kilo patient. That's 6 times 70 is 420. So that's about, how many cc's? 8, 9 mLs. This is 64, 10 times as much mics per kilo. And look what happens. See, the curve is linear both times. So it doesn't matter how much you give, it goes out at the same rate. So that's what the first thing they're proving. You give 10 times as much, it still goes out at a certain half-life, right? Now, here's the threshold for respiratory depression here. So if I give somebody 6, let's round it off to 6 mics, and that's 8 mLs of fentanyl, then I had the patient apneic for how long? About an hour. All right, then they're analgesic here because they got drug around, but then it's all gone after 360. So about 6 hours. So when I gave 8 mLs of fentanyl, I got about an hour's worth of respiratory depression. Hopefully that's how long the case is going to last. And I still had analgesia post-op, but the patient is breathing. That's good. And I had it for about up to 6 hours, at least some remnant of it. You're probably not getting much near the end here, but something. Does that make sense? Now, what if I gave 10 times that much? What if I gave 80 mLs? We used to do that to open hearts and stuff. Well, this the whole time, this is 48, this is at least 8 hours, and they're still not breathing because you gave so much, right? So this patient's going to be ventilated on a ventilator post-op, and you're not even going to try to get them back breathing, because what happens? If you gave Narcan here, number one, Narcan is always more potent than the narcotic. You can take Sufenta, the most potent narcotic we have, and I don't care how much you give, you can reverse it with Narcan. Because for some reason the antagonists have a much higher potency. So let's pretend I gave Sufenta, or fentanyl, and my blood level's here, and the surgeon goes, oh, I'm done. Oh, okay. Then I give Narcan, the patient's breathing. All right? An hour later, the Narcan wears off. What happens? you got deep doo-doo because the patient's going to go apneic again because their blood level hasn't fallen below the respiratory depression threshold. See what I'm saying? Now, what you want to happen is, let's pretend you get to this more realistic situation like we do in the real world. We don't give those high doses anymore. But let's say you got to right here. Oh, and the case ended, and you're bopping on, want to bop off to PACU. You know you haven't given any in about an hour, and you know the patient's going to start breathing any moment now, but they're just not ready to cooperate. And so you say, well, I'll give a little Narcan. So you give 0.1 or 0.2 Narcan. Patient breathes. It lasts an hour. Well, during that 1 hour time, the blood level fell to here. When the Narcan wears off, the patient's still breathing fine. They go home, they're happy, you're happy, the world is wonderful. See the difference? So you got to be careful that you're not giving it to somebody who's going to hang around up there for several hours. You have to make sure that, in your mind you can picture the blood level falling. You're just not quite there yet. Well, we've all had that happen. Some patients are just more sensitive, and you give 3 or 4 mLs and it seems to last forever. It's just another day at work. But that's the kind of thing you see. Now, this last computer simulation on the next page, and let's take a look at this here. And I think this is fentanyl, yeah. Simulation of intermittent dose of fentanyl for anesthetic lasting 1, 2, or 3 hours. So on the bottom here, they're showing 1, 2, or 3 hours anesthetic, and this is a 3-hour anesthetic, the 2-hour anesthetic, and the 1-hour anesthetic. And this is intermittent administration. So what they're saying is, let's pretend, well, they used about 15 minutes, I think. So they gave, let's say in this low dose one, they gave 400 mics total. So that's what, 8 mLs? Dear nurses, come on. All right, and then, so this is their 8 ml one. So they gave 2, waited 15 minutes, gave 2, waited 15 minutes, gave 2, etc. Or maybe they gave 3, 3, 3, whatever. Intermittent administration. And what they're trying to show here is very simple. I'm making this harder than it is. All right, if you do that, then every time you redose, you push the blood level up again, and so on. So at the end of the case, you have, look at the curves here. See, the blood level is going higher every time you redose it. So at the end of the case, your blood level is higher than it was in the beginning. So now you got to the end of the case. You don't need as much analgesia near the end to close, or to close the skin or whatever. But the most analgesia you need in the beginning when you stuck the tube in, the LMA down their throat, and the surgeon did the incision. But now instead, you made it the highest at the end. Now you don't know where the blood level is. Oh, well, if I give Narcan, then it's going to be up here, and it still may wear off, and it's a mess. So rather than giving intermittent amounts like that, what you want to do is give it all in the beginning, so it's doing one of these things, like it was on the previous page, right? We call it front loading. You want to, so let's say I'm going to do a gallbladder. And I decided this is a guy, he's healthy, other than gallstones. And I'm going to yank out this gallbladder. It's going to take 45 minutes. And I'm probably going to give 250 mics of fentanyl. All right? So I want to give it all in the beginning. So maybe I'll give 50 mics in the pre-op. When I get them on the table, slap the monitors on, give another 50 mics, hit them with propofol, throw the tube in, and give another 100 mics, and so on. So in the first 15 minutes after I've got my hands on this person, I've put in the 250 mics of fentanyl. Maybe not straight shot, but, you know, pretty fast in the beginning. And then, for the rest of the, you know, 45-minute case, I push it up to here, and then I just write it down. They got the most analgesia in the beginning when they need it, less at the end when they don't. They got some post-op pain relief. The patient breathes at the end, and I have a happy case. See what I'm saying? If I'm giving that intermittent, let's say I gave 1 ml, 15, 1 ml, 1 ml, 1 ml, then I'm doing the opposite of what I really want to do. You want to load it up in the beginning. Get it all in the first 15, if it's a 10-hour case, first 15, 30 minutes, and then even turn an infusion on and say, for example, if you're doing Sufenta, and then they have a nice, steady, calm patient, and so on and so forth. So I guess I'm just trying to get you to think in your mind what blood level you're producing by giving it the way you're giving it, so that you know at the end how much you gave, what you gave, how the patient's been responding, what the total dose is, when is the last dose, did I give one 90 minutes ago, I haven't given any since. Then the chances are, if I did that, they're going to be around here somewhere. But if I gave one 15 minutes ago and the surgeon said, oh, I'm done, all of a sudden, and I just gave a dose, then I'm worried that they're going to be up here somewhere. So then you're going to be more worried about where you take the patient to PACU, what you're going to tell the PACU nurse, and precautions. Are you going to pull the tube or aren't you? Are you going to give opiate antagonists or not? And all those types of things. So we control everything. We gave everything. We pick it, we give it how we want it. So then obviously you have to take that into consideration at the end. How was the patient? Did they intubate? Were they easy? I had to throw a tube back in. Could I? Yes, no. They don't want to take the tube out. If they were hard to intubate, then you let the cashier do it when they leave the hospital and pay their bill. Oh yeah, pull this tube out then. So anyway, I'm just trying to get you to think about what you're doing when you're dosing the opiates, so that you're giving it in a manner where the analgesia is loaded up front, and then the respiratory depression goes away. Okay? Okay, let's go to page 253, and this is from Dr. Hemming's book. I showed you some for the IV induction drugs and for the gases as well. He draws these cute little human beings and then puts the effect of the particular drug class in there. So let's go around. I'm on page 253. We'll go around the horn here from top to clockwise. So first of all, the opiates, opiate pharmacodynamics, a summary charts of selected effects of the fentanyl and fentanyl analogs. Supraspinal analgesia, that means CNS level. Meiosis, of course. Cough suppression, bradycardia, pruritus, delayed gastric emptying, and ileus, and constipation. Urinary retention. Depressed cellular immunity, I don't know, maybe. The opiates have an effect in cancer patients, that they have an immunity and help promote cancer. We'll talk about that a little later. The muscle rigidity that you can get from tight chest, from fast administration of high doses. Increased biliary pressure we mentioned, of course, respiratory depression, vasodilation for the histamine releasing ones. Analgesia at the spinal cord level, of course, nausea and vomiting, and sedation and euphoria. That's a little summary of the effects of opiates. Okay. All right, I quit. See you tomorrow.